1. We're live.
Welcome everyone, and thank you for joining this evening's meeting of the Health and Wellbeing Board, in spite of, I appreciate, a few technical difficulties this evening. I think, as most of you will be aware, Councillor Stephen Allen-Britis recently stood down as leader and also as lead member for adult social care and public health. And I'd like to take this opportunity at the start to formally thank Councillor Allen-Britis for his work on the board over the past few months. In his place, I'm Councillor Rebecca Lanning, and I was recently appointed as Cabinet Member for Adult Social Care and Public Health. So I look forward to working with you all on the board and beyond. If I may, I just want to take a few words at the outset before we go into the main agenda. And the first is to say just how pleased I am to be able to take up this role and to hopefully build on the legacy of Councillors Allen-Britis and Byers, who I think through this board in particular have really highlighted the importance of strong partnership work. And that's not just in meeting our health and care needs, but also delivering the outcomes that are meaningful and relevant to our residents here in Merton. And I think you only need to look at our collective response to COVID to see how fundamental it is to have these strong relationships in place and to make sure that we have an integrated approach to the commissioning, delivery and promotion of the services that we deliver. And with COVID in mind, I'd also like to put on record my thanks to all colleagues around this virtual table tonight in public health, the NHS, voluntary sector, children's schools and families, the environment and social care, who I know continue to work around the clock to safeguard all those in our borough. And I know many of you here tonight, but for those that I've not had an opportunity to meet yet, could I ask, for my benefit, but also for those who are watching from home, if everyone could very briefly introduce themselves and just give a couple of words on their role. I appreciate it's more challenging when we're doing this virtually, so if you don't mind, I'll just go around my screen and sort of mention each person's name if they could possibly introduce themselves that way. So could I start with Councillor Una Moulton?
So good evening, everyone. Councillor Una Moulton, Health and Wellbeing Board, and I've been a councillor since 2002 for Wimbledon Park. Thank you.
Thank you, Councillor Moulton. And Councillor Eleanor Stringer is next on my screen.
Thank you, Chair, and welcome, Rebecca. I'm Councillor Eleanor Stringer. I'm the Cabinet Member for Children's Services and Education, so I've been coming to these meetings for the past few months, and I'm an Abbey Ward councillor.
Thank you, Councillor Stringer. And Rob Clark.
Thank you, Chair. Welcome. My name's Rob Clark, and I'm Chief Executive of Age UK Merton and Chair of the Merton Health and Social Care Forum.
Thank you, Rob. And Dr. Mohan Sekaran.
Thank you, Rebecca. Mohan Sekaran, GP in Merton, East Merton Locality Lead and Social Prescribing Lead for Merton.
Thank you. Brian.
Okay, hi, I'm Brian Dillon. I'm Chair of Health Watch Merton. I've been a member of this board for about 3 years now. And I'm also, as it happens, I'm a trustee of MBSC. Thank you.
Thank you. Just moving across to Heather.
Hello, good evening. I'm Heather Begg. I'm a Commissioner in Adult Social Care, and tonight I've got my carers hat on, so I'm leading on the carer strategy work in Merton, but I also oversee the COVID-19 Community Response Hub and other preventative services.
Thank you, Heather. And Vasa?
Thank you, Chair, and congratulations on becoming the Chair, and we really look forward to your leadership in this very crucial time for people of Merton. I'm the Clinical Chair for Merton, and I look after the residents of Lower Morden and Morden.
Thank you. Jacob?
Thank you, Chair. I'm Jacob Lawrence. I am a Project Officer in the Recovery and Modernisation team, and I'm here to support Heather on the carer strategy today.
Great, thank you, Jacob. And Rachel?
Hi, I am Rachel Wardell. I'm Merton's Director of Children's Schools and Families. I'm pleased to be with you this evening.
Thank you, Rachel. And Sally?
Sorry about that. The usual problem. I'm now unmuted. Hi, I'm Sally Burns. I'm basically here as a carer. I have a son with a severe learning disability, and I've been involved with Merton MenCap and running a carers group for many years now. And I've been part of the task group working on the carer strategy.
Thank you, Sally. Thank you for joining us this evening. John?
Good evening, everyone. My name's John Morgan. I'm the Assistant Director of Adult Social Care here in Merton, and I'm here to present the carer strategy with my colleagues.
Thank you. Just moving over to Jenny.
Hi, my name's Jenny Quested. I'm also a project officer on the Recovery and Modernisation programme, and previously was on the graduate scheme with the council, which is where I was supporting Heather Begg with the development of the carer strategy.
Thank you, Jenny. Moving on to Hannah.
Sorry, colleagues, nearly forgot to take off my mute. Hello, good evening, everyone. I'm going to apologise first for the technical difficulties, and thank you all for being so patient. I'm Hannah Doody. I'm Director of Community and Housing in Merton. Thank you.
Thank you, Hannah. And Mark?
Oh, I'm Mark Croman. I'm the Exec Lead for Merton and Wandsworth in South West London CCG, and apologies for my lateness.
Thank you, Mark. Dagmar, I think we have you on screen. Yes.
I know. Hello, I'm Dagmar Zoyner. I'm the Director of Public Health, and thank you for rescuing me, Dave. You've got me the link in. Lovely to see you all.
Thank you, Dagmar. And Dave, we have you on screen next.
Oh, is that me? Sorry,
yes,
I've just come back in. Yeah, Dave Curtis, Head of Health Watch.
Thank you, Dave. I think I've got Clarissa on there next.
Hi, sorry, just trying to let the final people in. Chris Lee's saying that he's sorry, he's trying to join us at the moment. So I'm Clarissa Larson, and I'm Partnership Manager for the Health and Wellbeing.
Thank you, Clarissa. And Chris, we've got you directly next on screen. We're just going around doing introductions and just a brief couple of words on our roles.
Great, thank you. I'm glad I could finally get in. So I'm Chris Lee, Director of Environment and Regeneration, so responsible for public realm in Merton and a member of the board for a couple of years now. Thanks. Thank you, Chris. I've got Sarah.
Oh yes. Hi, thank you. I'm Sarah Keane. I'm from South West London CCG, CAMS Transformation Manager, and I'll be presenting on the CAMS strategy for the borough.
Thank you, Sarah. And Simon. Oh, Simon, I think you might still be on mute.
Sorry, I'm having a Boris with the technology, but yes, evening everyone. Simon Shimon, CEO of MVSC.
Thank you, Simon. And finally, I think we have Karen on the line.
Hello, everybody. I'm Karen Worthington. I'm a GP in Morden. I'm the Deputy Clinical Chair in Merton. And I'm also the named GP for Child Safeguarding in Merton.
Thank you. And thank you everyone for introducing yourselves. I look forward to working with you all. And just turning to the agenda, I think the first item was apologies for absence. And I think we have one from Aditi Shah. I don't know whether we have any further apologies. Clarissa?
No, none so far, no.
Lovely. And then declarations of pecuniary interest. Are there any declarations? I will take that as no. And then the third, and I'll defer to those who were present at the last meeting. Are there any comments or questions on the minutes of the previous meeting? Okay, I'll take that as a correct record. And now just moving on to item 4, which is the COVID-19 update, which I will hand over to Dagmar to present.
Thank you. Thanks very much, Rebecca. I have got a few slides with you to share. So just as a quick reminder, we as a Health and Wellbeing Board are an important part of the governance of outbreak control, which is a important duty of the local authority. And so at the beginning of the Health and Wellbeing Board, I want to make sure that we all understand where we are. So a bit of situational update. I will also briefly update you on the major developments in our sort of outbreak control toolbox. And then very briefly mention a sort of a quick digest of the new winter plan. And hopefully leave some time for questions and get a little bit of time back. Ooh, that's a tall order. So Clarissa, you help me. I won't dwell on all the slides. I will whiz through and just highlight a few. If there are questions, even afterwards, do always come back. We want to make them as accessible as possible. And so any feedback that you can offer us is really, really welcome. So if you move us on. Clarissa, can you move the slides for me? Oh.
Can people not see the slides?
No.
Could anybody else see them or?
No.
No, okay, let's try again then. They look like they're sharing at this end.
Yes.
Oh, so, right, good, okay.
Yeah, we've got them. So quick update on the weekly key messages. No, don't go quite as fast. So the main indicators, as you will remember, is our weekly rate of infections over 100,000. So it's important that it's per week. It has actually on this slide gone up. It's quite dramatically high now, nearly 200. But the good news, hot off the press, is that over the weekend, this is obviously lagging behind, has now seen a slight decrease. So I hope that we are over the worst. Some good news even on that slide is that the over 60s infection rate, the weekly one, has slightly decreased. As you're aware, those are the ones at highest risk and therefore our biggest worry. In terms of testing, I won't dwell on the results, but drawing to your attention that our daily testing rates are actually up, which is positive because we obviously say anybody symptomatic, please get a test, and there are no more shortages. All varieties of tests, home tests, drive-through, walk-through, mobile are now accessible. So important message for all of us. If you move us on. It's a reminder of the death, and I don't again want to go into the detail, but one of the things that you will notice is that we compare our weeks with last year. That's the yellow line. You still see the very ugly spike from the spring, and you do see now that we are developing another, albeit much smaller, hump. Which obviously is the really tragic hard bit of the pandemic. And one thing that we all grapple with is that part of that are COVID deaths, but there's also an increase in non-COVID death. And it was a phenomenon in the first wave. You see it very clearly there, and it seems to appear again. But numbers, luckily, at the moment are still small, so we are not jumping to conclusions, but keep an eye. If you move us on. This is the now familiar what I call the tiles, the London tiles, and on one side you see the weekly infection rates, and on the other side you see the ones in the over 60s. Merton used to be a little bit behind the rest of London, so it was had lower rates, but it has now caught up with its neighbours. If we move on. And this is quite an important one. You see that there was a bit what I call a hump. And in fact, the grey line was Kingston, and everybody was pouring over Kingston saying, what is happening? One of our neighbouring boroughs, we actually couldn't find anything specific. And so it meanders a little bit. But as I said, from over the weekend and today, it is now on its way down again. If you move us on. This is a really important slide for the Health and Wellbeing Board. We are very committed as a board around fairness and reducing inequality. So we are monitoring very closely the East-West discrepancy. You will see that at the beginning of September, the West was racing ahead. And there are some suspicions that this might have been due to students, but students still registered as residents in Merton were actually studying in northern universities with big outbreaks, which is now been rectified. We now see that the lines have crossed over and the East is a bit ahead. But as I said already, this curve is now coming down again. So we're keeping a close eye. And then, Rebecca, you asked a while ago for us to look at ethnicity. So we are getting the data now. And encouraging signals at the moment is that there isn't a particular disproportionate noisy signal for ethnic minorities. But again, we want to work very closely with our NHS partners as well to see whether that is translated into who goes into hospital. If you move us on. This is important because I showed this last time to you and there was a clear pattern on the left-hand side. And we call it the heat map, so different age bands with different colors according to infection rates. And you can see clearly that the youngsters are the most orange. And previously there was a bleeding into the older age groups that has reversed now a bit, and I've just come off a call. So across Southwest London and indeed London, we've got more youngsters again, and so quite a brunt in schools. If you move us on. And this is the last slide. This is really important about the impact of COVID. If you have mild COVID, we wouldn't make a fuss, but it's the problem if it turns nasty. And these are hospital admissions. You will see the turquoise is our Southwest London, so it's not Merton. This is Southwest London data. And we've been hovering at the bottom, and that was very obviously good news. We've now crossed over and caught up. In terms of the more severe end, intensive care, we're still pretty much at the bottom in London. On the left-hand side, a very important slide as well, and our NHS partners would know more, but it is the general occupancy in the NHS. It is busy, but it's still, they're coping with incapacity, and the message is very clear, the NHS is open. That is an important message. And I've just added a London slide on the right-hand corner. It shows you a bit about severity. So we are seeing the more severe end of COVID now. The red columns are actually patients with mechanical ventilation. That is really serious stuff. If you move us on. So that was a canter because I wanted to get a bit of time back for Rebecca. If you bear with me, I will talk you through that slide as well, and then we take questions if that's okay. So this is only one slide, but it's pretty important because we are having now three major sort of developments of some measures to contain COVID that are a bit more promising than our rather sort of clunky restrictions and social distancing. So one is local contact tracing. So we've launched in Merton on the 18th, so it's very fresh off the press, and already 24 cases successfully contacted. What is very important to understand is that we're not taking over NHS TNT by any stretch of the imagination. We are explicitly complementing, and we are looking at cases that NHS TNT cannot get in contact with. We are not then following up the contacts. We hand those cases back. What is very important is that with a more local, what we call case finding, we can do link up the cases with our local support services, and that has already been, in terms of very brief feedback, very much appreciated. So watch that space. I think for longer term containment of COVID and living with COVID, refining the complementary local contact tracing, really important. Once infection rates, to look at what we call backwards tracing, so doing a bit more of the detective work. If we have a case, where could the case have got it from, and how can we interrupt transmission chains? So good on Merton to have started. The next one is testing, loads in the press. I won't go into all the glorious details, but there's also a lot of misunderstanding about what tests can be used. There are some exciting new developments, but just for iteration, symptomatic people, anybody with the classic symptoms must get a test, should get a test. It is not a problem. There are 2 bits, pillar 1 from the NHS, pillar 2 from DHSC. These are all the community sites, including local sites. You will have to get the swab, and the swab needs to be sent to the laboratory, and there is a very accurate test, which is called the PCR. So that's the gold standard, which we had so far. What is now held and has been all over the press is a new device, which is called an LFT, a lateral flow test. And the interesting bit there is that the test doesn't need a laboratory. It's like a little pregnancy test. You've got the laboratory inbuilt. You still have to swab. You can do it yourself. And then you have to wait, and between 20 and 30 minutes, you get a line or not. Now that is a new real technological advance, and opens up a lot of new opportunities. We are very keen that we use the tests purposefully. That is, for me, the biggest learning from Liverpool, where they use them for everybody. I think we want to use them initially very purposefully for visitors in care homes, for example, for special needs schools. We are at the moment refining in high priority settings where this test can help us a lot. And I think watch that space, because lots of national developments coming our way as well. And then finally, also very exciting, because a real tool for getting somehow a grip on COVID is the vaccination. So it's led by our NHS partners, but I think as a system we all have to really pull together so that we have an equitable benefit from the vaccination. And at the moment it is preparation going on. Primary care is a very important partner in the delivery, so are the community services and the NHS. As you will have heard in the press, the vaccine doesn't make it easy for us. The ones at the moment furthest ahead is the Pfizer one. It needs some very cold temperatures. So there are some practicalities that need to be worked through in the logistics, but generally this is good news stuff to liberate us from COVID longer term. So exciting, some new tools in our toolbox. And next slide. That's very briefly, and it's only a brief summary, but you will have heard the COVID winter plan was published yesterday, and it describes a bit more the ceasing of the lockdown, the new tiered approach. It isn't radically different from the old one, but we are not yet sure where London will end up. The winter plan clearly says it is a regional tiered system. So we assume, as we have before, London sticks together as a region. Announcements will be on Thursday. So that's a quick canter through, but us as a Health and Wellbeing Board in charge of overview of COVID, I wanted you to be aware of those things, and happy for questions.
Thank you ever so much, Dagmar. And I think as usual, a huge amount of data that's been condensed for our consumption, and also some exciting innovation and developments that I know that colleagues are adapting to. Could I open up to questions or comments for Dagmar? Mark.
Chair, just a couple, just in terms of the vaccinations. Obviously there's the mass vaccinations, and then if we call them primary care PCN vaccinations, but also that we are working with our partners in the roving vaccinations, so people that can go into the housebound and also go into care homes, etc. And I just wanted to reiterate Dagmar's very very helpful. The NHS is still here. It is busy, but it is still open for business, and that includes things like flu vaccination. So we want to encourage people to still come forward and get their flu vaccination ahead of their COVID vaccination. Thanks.
Thank you, Mark. I think I also saw Councillor Stringer.
Thank you, Chair, and thank you, Dagmar. That was very informative and clear as ever. And I'm going to ask a question about schools, as you'd expect. So we had rising numbers in schools again, which is entirely understandable and backed up by your data of younger pupils. I just wanted to check on your thoughts on whether schools have got all the support that they need to do their jobs in their tracking and tracing. In particular, I gathered that there's been some discrepancies recently between the advice that schools have been receiving from DFE and from others, and whether you think that how much of a problem that causes. Thank you.
Of course, when there's inconsistency, it's tough, and we're trying, between Rachel and myself, we try to iron out. There are human peoples at both ends, at the DFE helplines and the LCRC helplines. So we forgive that, and they do their quality assurance, but there were some principal misunderstandings as well. So I think we've gone back and ironed those out. What we've had on a previous call I was on just now is that schools in London have been actually really avant-garde in that they have done quite a lot of the risk assessment and contact tracing for uncomplicated situations themselves. It was a pilot because London was the only one where that was tested with a pack. And the learning from London is quite phenomenal, that even the thresholds that LCRC has put into the pack to ask schools to get back to them are now actually too low. So schools can basically do it really well. And so what LCRC wants to do is to empower schools more and say, actually, if you haven't got a problem and if you feel confident, then you do not just report to us. I think that will help because a lot of schools now are confident. We also have a loop if they have any question. In Rachel's team, Elizabeth is just absolutely brilliant. We've got a good link to the head teachers, and because LCRC is so overloaded, that it's quite an additional task for the school to try to ring up LCRC just for the sake of it. So we are ironing out that bit. I think your point around where are schools going is very important, and as I mentioned, the LFTs, the lateral flow devices, there has been an announcement in the winter plan, not particularly elaborate, but an announcement that expectation is schools will also be included lateral flow devices, so they can use them a lot more as a self-service as well. Possibly that need to self-isolate, because you will have heard one of the phrases is now test for release. So if you have been identified as a close contact, but you are asymptomatic and you're in a crucial position as a key worker, if you test for 7 days every day, and the test is negative with the lateral flow device, then you can continue. That is obviously really quite changing for a school environment, and we are very keen to support schools with that. Sorry, that was a bit long, but a lot is happening.
Thank you. Thank you. Thank you, Dagmar. Rob.
Yeah, thank you, Dagmar. Really helpful presentation as ever. Just sadly pulling us back to the slide on deaths. I got a question really, to what extent do we need to worry about that? Do we know much about cause of death? And do we think that that's symptomatic of the indirect impact around COVID that we've talked about previously?
Yeah, so we're a bit more confident from the first wave because the numbers were so much higher. So if you go back and you see at that the graph, the majority of that what we call excess death in the first wave were actually non-COVID death. Now there is a little bit of problem in there, that in the first wave we didn't test everybody. Yeah, so part of those what are labeled on the death certificate as non-COVID death probably had COVID. But as you are aware, a lot of people who die with COVID have a lot of other conditions as well. So there is a little bit of blurriness on the death certificate as well. But I think what we will find is that it is not a unicausal explanation. There are multiple causes from how the death is registered, some undetected COVID, and possibly, particularly in the first wave, some evidence that people did not present early enough. I would think, because the message about the NHS is here for you, the NHS is open, is different in the second wave. So for me, we obviously we'll do a lot more analysis of the death coming, but the signal about people having missed out on healthcare is much weaker at the moment than we had in the first wave, and we are very aware of it. So that, for example, the support in care homes as well is there is proper clinical support in care homes, and not just saying, oh, if it's COVID, then everything is too late. So I think really important that we've learned. And the good news, as I said as well, around ethnicity, we haven't got the ethnicity of our death yet. They are delayed. But in terms of the signals we've heard from the hospitals, is that even those in ITU and on ventilators, we haven't got the disparity, the ethnic disparity. It's not noisy signals, so we obviously keep an eye, because more will come. But that is all encouraging, that we've learned something, and that our interventions not solved it all by any chance, but by any stretch of the imagination, but have had some impact.
Thank you, Dagmar. Rachel, do you have a question?
It wasn't actually a question, Chair, but I wanted to support some of what Dagmar had said in relation to our schools, and also flag one issue. So the schools have been tremendous through this period, and they're working very hard to stay open for children in support of their education and their wider well-being. It is a challenge because of the numbers of cases in schools, and because of therefore the number of people who have to isolate in response. Dagmar is right that some of our schools are now very experienced, and for them a call to the LCRC may well be unnecessary, but what I wanted to point out is that that is by no means uniform. So if the LCRC raises its threshold, what it's doing is it's withdrawing support from some schools who have not yet ever had a case, and when they do have a case, they won't have the same confidence level that other schools around them have developed. So it's just a reminder that lots of schools are in very different positions from each other. They will of course be able to rely on each other for support, and there is a really good network in the Merton family of schools, but just wanted to flag a little bit that as LCRC kind of retreats, some schools will not have encountered even their first case yet.
Thank you, Rachel. Were there any other questions or comments?
May I?
Can I go to Dagmar first to respond, and then Vasa?
Yeah. I just wanted to make sure that there isn't a misunderstanding. So I think LCRC not encourage a school that needs support from phoning. What they wanted to signal is to liberate schools who feel it is just an obligation to phone LCRC as part of the pathway when they do not really feel they need additional support. That's quite an important nuance, because it is not that they want to step out of their space of supporting schools who want it and need it.
Thank you, Dagmar. Vasa?
Thank you, Chair. I just want to emphasize what was said earlier, but we really must say it strongly. We must try and get all our traditional winter flu immunizations done this month. So there's sufficient gap when the COVID campaign starts that no one is delayed the COVID vaccine because of the time gap required between the two. And when it goes back to mortality, having both together in January or February is not a good idea from a patient point of view. And I say both together, both the illnesses together. So even if you're unlucky and get one, it's better to at least be protected from the traditional winter flu. So we really can't overstate the need to get maximum traditional winter immunization done now, today, okay, till tomorrow.
Thank you. And Brian, I think you had.
Yes, thank you. I got a couple of questions really. It's good to see we're not spiking on these on the new stuff, Dagmar, which is quite encouraging. My main interest is in people who haven't got COVID, everybody else in the community. And really, it's probably for Mark actually, how are we really holding up on the non-COVID treatments, the non-urgent stuff? Are we still, are the hospitals still up to speed? I mean, how are we compared to last year, sort of pre-COVID times? And the other thing is, I'm a bit concerned about the impact of the vaccination program. It's for Vasa really, whether that's going to further impact on services from the GPs to the general public. That's it. Thank you.
Vasa, did you want to come back on that point?
Thank you, Chair. So yes, you're quite right. If we had to divert our staff to do COVID and only we did COVID, I think what you say is quite valid. But thankfully, cavalry is coming. Extra staff are being trained. People who never immunized before are being trained to immunize. And I think that type of additional workforce, which will help us in the new year, will actually allow us to do double running. We can do our day job and we can do COVID, and others can help us do COVID. So I think that extra additional workforce, which is being selected and being trained as we speak, literally, I think that's really going to help us achieve this. And double running is important. We have no option. We have to double run. And our hospitals are currently double running, and they are zoning and they are segregating the staff and the wards. They're doing a really difficult thing to do, double running, but they're doing it. And so far, we have been able to do it.
Shall I come in just for activity?
Thank you, Mark.
So I think South West London has done relatively well just in terms of playing that kind of catch up, if you want to call it that, where a lot of the elective cases and outpatients that at the very peak of COVID weren't done. There's obviously been a great program, a massive program to kind of catch that up. In terms of activity, we had the most recent kind of cancer weights data said that we were actually achieving our target. So that's really good news. But actually, as more people come through the cancer weights and are referred in, obviously you will get people that are then need to be seen for treatment of cancer. So there is a kind of knock-on effect. I think in terms of things like electives and outpatients, I think the last figure that I had was at about 89% of activity compared to last year. And that's that's a fairly good response. That will change though, as we see pressures on different hospitals across South West London, and hospitals are working to kind of shift activity amongst themselves, where, you know, if there's a pressure in Kingston, electives may well swap across to St George's. So there was a kind of mutual aid going on, which I hope provides some assurance. And then finally, I'd probably say also in mental health, and I know we've got cans later on, we are seeing above last year's activity quite significantly on mental health referrals from primary care, community settings, and the more acute settings as well. So that's much higher than it was last year.
Thank you.
Thank you. Do we have any final questions or comments for Dagmar? Great. Thank you. And I think I speak on behalf of the board to say thank you again to Dagmar for all her work in pulling together. So moving on to agenda item 5, which is Merton Carer Strategy 2021 to 2026. And I'm delighted that we have Sally Burns and Heather Begg, and I think also other members of the team who will be presenting this item for approval tonight, and also for us to consider how through our respective organisations we can support in implementing against the 11 priority outcomes. So I'll hand over now to Heather and Sally to present on this. Oh, and John?
Yeah, Rebecca, John's going to start us off and then I'm going to finish.
Thank you.
Okay, so myself and my colleagues are here this evening to present Merton's 5-year carer strategy, which covers the period 21 to 26. Before I start, I would just like to begin by thanking informal carers for all that they do. Since the pandemic started in March, informal carers have stepped in to provide even more care and support to their loved ones than they already did. We as a system owe a debt of gratitude to carers, as the support that's been provided has been fantastic. As a system, we would not have managed as well during this pandemic without the huge level of support provided by carers. But this extra support has taken its toll on carers. A recent Carers UK national report indicates that 70% of carers are providing more care, and 55% of those carers reported feeling overwhelmed at times. In Merton, we estimate there are approximately 20,000 carers, although many don't recognise themselves as carers and receive little or no support to support them in their caring role. We often don't get to know about these carers unless there's a crisis. They're not able to continue with their caring role, and we have to provide some support. The 2019 Adult Social Care Annual Carers Survey, and in the same year, the Carers Survey from Carer Support Merton highlighted some of the biggest issues carers faced prior to the pandemic. Of those surveyed, 68% reported that their caring role has negatively impacted on their well-being. 70% reported that their physical health had been negatively affected by their caring role, with 64% reporting loss of sleep. So this is a perfect time for us to present our carer strategy, as we need to improve our offer to carers and the way that we work together as a system. A good way for this to happen, of course, is that this strategy has been co-produced by the system, by carers themselves, by the council, the CCG, our mental health trust, and the voluntary sector. And I also see that Mohan, one of the board members, has also been involved in the implementation of the carer strategy as well. So we have 4 people presenting tonight. The first one is Sally Burns. She's a parent carer and also an Adults First representative. And Sally's going to be given an overview of the process from a carer's perspective. Then we're going to move to Jacob Lawrence, who will speak about the engagement that helped to shape this strategy. Then it's Jenny Quested, who will be talking about the work on refreshing the strategy as a result of COVID-19 and the impact that this has had on carers. Finally, we're going to move to Heather Begg for what I view is one of the most important sections. When we started work on the strategy, Hannah Doody and myself were clear that we did not want a wonderful, beautifully written strategy that was beautifully bound, that would go onto our shelf and gather dust for the next 5 years and only brought out to show the work that we'd done with carers. We wanted something that would actually make a difference to the caring role in Merton. So Heather's going to be speaking about the implementation plan and what happens next with this strategy and what we're going to be asking you to support us with. So I'll move you across to Sally.
Hi, thanks, John. Well, as you've heard twice now, I am a parent carer. I've lived in Merton for getting on for 45 years. I have a son in his early 40s who has Down syndrome and an enormous range of medical problems. I have far too much contact with the health service one way and the other. I've been involved with Merton MenCap since he was tiny. I ran the Carers Partnership Group, which was for family carers of adults with a learning disability, for about 15 years. And now I'm on the MenCap Adults First Steering Group, which does the same sort of thing. And as that, I represent carers on other groups, for example, the Patient Engagement Group, which was meeting earlier today. So I get to meet a whole range of other carers as well. I was involved with this task group since summer 2019, a very long time ago when we started. And it was a very good group. As John has said, I think thanks mainly to the hard work of Heather and her helpers, they managed to get together a really good range of the people who needed to be involved. So we had obviously people from the local authority, public health, primary care, mental health, the voluntary sector, MenCap Carers Support Merton Dementia Hub, the DWP on the employment side, plus of course carers. So we started from a good base. On carers, what do we actually know about carers in Merton? We're talking here about an enormously wide range of people. We're talking about young carers helping out in the family home. We're talking about people like me who was once a parent carer of a young person. I'm now still a parent carer of a 40-year-old with a severe learning disability. We're talking about partners coping with their partners, maybe early onset dementia, people with mental health problems. It is an enormous range, and the numbers are, as I think John said, reckoned to be somewhere between 16 and 20,000 and rising due to COVID. Some of these people will be caring for a relatively short time, maybe months or years. A lot of people are caring for a lifetime. And it does have an enormous effect on all our lives. As John's mentioned, it affects our physical health, our mental health, our ability to work, hence our income, our chance to just have any sort of social life. And it doesn't just affect the primary carer, it does affect the whole family. But despite this enormous spectrum of carers, types and needs, we picked up a lot of common threads when we did the consultation. Now, I know Jacob's going to be saying more about this, but I think it was good consultation. It was a mix of online, paper questionnaires and going out and talking to groups. And it had to be good because it was the results of that consultation that fed into the strategy. It's precisely what it's based on. We found out what existing help carers really value, but probably more importantly, we found out where the gaps are at the moment. We were looking at identifying carers, supporting their physical and mental health, helping them to work or volunteer if they want to, and how on earth we let them have a life alongside caring. And you can tell from that remit that an awful lot of organisations and people are going to have to be involved if we're going to have any hope of meeting those needs. It's going to be Merton Council, not just the obvious departments. It goes across the council, thinking of carers in everything they do. A whole range of health services. I mean, I, like most carers, am already heavily involved with a lot of different health services for the person I care for. But what about the carers themselves? Who looks after them? It goes across the voluntary sector. They've got a very big role to play here. In local employers in the borough. And if I think over the 40 plus years I've been caring for my son, the range of organisations that have been fantastically helpful, it is just enormous. The priorities for our first year are set out in no particular order on page 9 of the strategy. I'm sort of assuming, hopefully, that you've all had a chance to at least glance at it here. I say they're in no particular order. What we have realised, and Jenny will be talking more about this later, is that the impact of the pandemic is that we maybe reassess what's the most urgent things to set to. Some of these things has already been some progress on. One thing that immediately loomed large was the need to improve digital access. And I know people are discussing this across the borough. This affects carers in particular in so many different ways. And we realise that there are quite a lot of people out there who are really struggling with this. The good news is that I know work's already underway in the NHS and local council, but also in the voluntary sector. Both Carers Support Merton and Merton Mencap, and there may well be others, are already starting work on looking into this problem and what we can do about it. What we'll see also, if you look at that list of priorities, is that clearly some things are easier and require less resources to start to fix than others. For example, improving some council processes so people actually get bills on time for the right amount should be fairly, I hope, fairly easy to fix. Similarly, making sure that GPs do recognise and record who are carers and make sure they point them in the right direction. Drawing up emergency plans for carers, I think, should be a fairly straightforward process. But if you look down the list at the last two priorities, quality services for the cared for and respite, for many carers, these are the absolute linchpins. These are the things that keep them going and they rely on. And we have to see that those are going to be harder to tackle when budgets are under threat. It's going to take concerted action. But what I would urge you all to do is to see carers not just as people you hopefully feel you have a moral duty to support, but also as a fantastic asset in this borough. We work so hard to keep the people that we love healthy and happy. It is a workforce out there working the whole time on your behalf. I did a rough sort of back of the envelope calculation using the latest Carers UK estimate of the value of carers' work, which they put in at around £19,000 a year. And obviously there's an enormous range. And actually I took the lower estimate of about 16,000 carers in Merton. And even on that basis, this represents over £300 million worth of work each year. So roughly 5 times the current adult social care budget. We are a great asset, but you can lose those assets. Carers need looking after and nurturing if they're going to be able to go on caring and have a decent quality of life. And if there's not the preventative work early on and support put in then, more of us will succumb to mental health crises, physical health problems, and some won't be able to go on caring, and some indeed will die earlier than they should. I ran this carers support group carers partnership group for many years, and one of the saddest aspects of that was seeing friends and colleagues dying prematurely, considerably younger than I am now in some cases, many of them of stress-related illnesses. And when that happens, the whole responsibility for caring passes over to health or social services. And we've got to try and stop that happening. So that's why, as John said, we need to make sure that this isn't just a list of good intentions set down in writing. Right at the outset, I was very heartened on joining this group because it was seen as a framework for action, action being the key point here. I really genuinely believe that the things contained in this strategy can make a difference to our lives, but we've got to put them into action. And that's what I very much hope between us will be working on next year. Thank you.
Thank you, Sally. So from the very beginning of this process, we knew that meaningful engagement would be central to both the design and the success of this strategy. So as with all parts of the strategy, we co-produced our engagement plan for this project with the task group, deciding on a 3-phased approach. So the first phase was a survey for carers, which gave us the qualitative data on the types of carers responding, the services they accessed, and their views on how Merton's offer was for them. This was distributed both online and via post so that carers who did not have access to the internet could feedback their views. And in total, 131 carers were able to share their views via this survey. Phase 2 was focus groups, which we used to draw out insights on what works well, what doesn't work well, and what should be included in the carer strategy to ensure it's able to make meaningful change via its delivery. We attended various carer support groups, including, but not limited to, Carer Support Merton, Adults First, Kids First, and the Dementia Hub, all of whom do pretty fantastic work for carers and the people they support in Merton. We also advertised and facilitated 4 of our own focus groups so that carers who didn't belong to such groups were able to participate in this. And in this, 70 carers were able to share their views through these focus groups. And then on to phase 3. So phase 3 was engagement with staff and practitioners. Here we facilitated focus groups with staff from Merton's adult social care teams, as well as some of the voluntary sectors and health partners who support carers. And in a similar vein to the focus groups with carers, this provided us with insight into what best practice looks like, what challenges to effective practice there are, and ideas about what could be better in Merton's offer to carers. As well as this, it also provided us with some early thinking as to how the council could better support its own employees who are carers. And indeed, as one of the biggest employers in the borough, I think the council has a responsibility to kind of lead the way, set best practice here. So this engagement really was central to shaping the carer strategy being presented today, but it also helped us deliver a couple of quick improvements which could make a difference. So following discussions with carers, we were able to update and improve our online information and advice offer, and work was also undertaken to increase the amount available to carers through the carers discretionary grant. And I think now I'm going to hand over to Jenny, who's going to speak a bit more about the strategy.
Thanks, Jacob. We were originally due to take the carer strategy to the Health and Wellbeing Board for sign-off in March earlier this year. For obvious reasons, when the emergent issue of the pandemic took precedent on the agenda of that Health and Wellbeing Board, the decision to table the strategy for a time prompted us to reflect on how we could ensure the carer strategy took into account the huge impact the COVID-19 outbreak has had on carers. So later on in June, the Health and Wellbeing Board members requested that the strategy should be brought to an upcoming board, so this one, which prompted the Task and Finish group to reconvene and begin work in earnest on taking stock of the changed landscape for carers in Merton. It was abundantly apparent from survey results detailed in a Carers UK report in April that John mentioned, alongside other charity reports, as well as our own local anecdotal evidence, that a number of existing issues for carers have only been exacerbated by the challenges brought on by COVID-19 and associated restrictions. Just a few of these challenges, as both John and Sally have mentioned, have been things like increased isolation, heightened anxiety, as well as burnout and the increased risk of burnout as a result of intensity and duration of caregiving. So it's really important to reflect these challenges in the strategy, as well as the huge, although possibly temporary, increase in the number of informal carers as a result of the pandemic, due to factors such as schools closing, shielding requirements, and obviously individuals developing new health issues. So when we were reviewing the strategy in June against this evidence, it was reassuring to see that the strategy's original priorities still stood up. Indeed, a number of priorities and their key themes had only strengthened in emphasis. For example, again, as Sally mentioned, the issue of a lack of digital access among carers has only been accentuated by the COVID-19 outbreak, and the way in which this therefore disproportionately affects carers' access to support, information, and social activities, which is so important at this time. We wanted to ensure that the strategy would remain relevant over the course of its lifetime, so up until 2026, when hopefully it'll be refreshed. So therefore, we thought it was important to keep the original strategy outcomes and the engagement that Jacob mentioned as the core base, whilst including a box alongside each priority in the strategy. And these boxes kind of, within them, we highlight some of the key ways that the respective priorities were affected over the course of the pandemic and still are. And in some cases, the action that's been taken already, or what our aims are to overcome the emerging and exacerbated issues. So the implementation plan first year of the strategy was also developed over the last few months. A number of the actions within this are responsive to the issues that are now more significant than ever as a result of the pandemic. Prevention is a key element, again, of this, and it underpins the implementation plan and the strategy in order to support carers before they get into crisis. So I'm now going to hand over to Heather, who's going to speak a bit more about the implementation plan.
Thanks ever so much, Jenny. So you would have received a copy of the implementation plan in your agenda pack. So as a task group, as Sally mentioned, we have chosen 11 key priority outcomes for the first year. It was actually 10, but we snuck another one in, which was very much around carer-friendly work environments. And we're really encouraged that actually the CCG really wanted to prioritise this. And we as a council and as part of the health and wellbeing strategy want to look at our work environments as well. So that's something that's kind of in development and we're having active conversations about as we speak. So we've got 11 key priority outcomes for the first year. And as Sally said, one of our key, most important outcomes, top one, is around digital inequality. So promoting digital equality for carers has become really, really pivotal. And we've made a start with developing these actions. So it's a very high level implementation plan. But as we work through these actions, we'll become a lot more smarter. So once the strategy has hopefully been approved by the Health and Wellbeing Board today, we will look to get an external design team to kind of format the strategy so it's presented in a more accessible and attractive format. But as John said, it's not going on that shelf to gather dust. It's very much about the doing. So we will hopefully morph our task group, which has been a really fantastic, really very passionate, full of energy and very motivated to improving things. And we want to keep that energy going forward to transition into the Carer Strategy Multi-Agency Implementation Board. Really catchy title there. But John Morgan's going to chair that board, and we'll have lots of partners around the table, and it'd be great if there are other people on this meeting today. If you want to be part of this, please do let us know and we can bring you in and join you in with the board. So we want it to be very much multi-agency with a number of partners. As Sally said, it's everybody working together on this, but most importantly we need carer representatives there as well. So we really need to hear from the voice of carers, and it's been wonderful to hear from Sally today to really kind of give a flavour of what this carer strategy is all about. So we plan to launch the strategy in January, so we're hoping I'm probably going to organise a meeting in a couple of weeks to look at what that looks like. It's probably going to be an online launch, maybe a bit of blended activities as well. And we'll follow a similar format. There was a Carers Festival celebration event that ADAS put on in September, which was really successful and had hundreds of carers across London join that online. Some people had never used online activities or accessed them before, so it was a good opportunity. We'll also use the event to recruit some carers to the implementation of the strategy. We'll envisage that not all of this work can be done by that one single board. That board will oversee the work, and we envisage there'll be separate task groups for particular pieces of work. And for example, there'll be a young carers task group which will sit under the implementation board that will drive some of this work going forward. And actually, we've got a meeting first thing tomorrow morning to start looking at that work. And we hope to come back to the Health and Wellbeing Board with a really good progress update in 12 months. And And I think you'll agree that there's a lot of content in this implementation plan for year one. We haven't included everything in the strategy. There's lots to do. But what we really do believe is that there's a lot of things in here, as Sally said, that can be achieved. And, you know, I'm really looking forward to us getting going in January to kind of start delivering on these outcomes. Thank you, everybody.
Thank you all, and thank you for taking us through what is such an important and dynamic strategy. And I think really wonderful, as Heather said, to hear that it's a strategy that's being designed and led by carers, you know, the actual group that we're looking to actively support. So could I open out to questions or comments on the strategy itself or the implementation? Mohan?
Thank you all. Excellent. I mean, that's I haven't really got much to say, which is unusual. But you've hit all the pertinent points there, and this really does hit an example of, you know, good proactive preventative care, catching people before they become unwell, and actually not an individual patient, but actually the people around them. Because if that goes, then we're all in trouble. So I really look forward to working on this, starting on this in the new year. And I think a challenge around the digital bit as well. It'd be nice to sort of work out how we can sort of get over that. But I yeah, fully support this, and my name's on the strategy. So definitely, yeah, good work. Thank you.
Thank you, Mohan. Councillor Moulton?
Thank you. I mean, I really welcome this strategy because and the implementation is it's really clear. It's very well set out, and I think you've introduced it tremendously well, and I really commend it and hope that, you know, we succeed on this. And I use the word we because when I actually have been a carer, I use the word historically because sadly my mum passed away, but I certainly know that, and I can put it as hard as some trauma that I went through. So, and I think it, you know, when you're a carer already with 3 children in my case, and then struggling with my mother, I found it very, very tough. So I do know, and I really think that trying to reach out to people, and it's sort of, you know, you don't necessarily think of yourself. That's so true as a carer. So there's, and I think this is the real importance. And so many people actually do need somebody to talk to who's not necessarily their own, you know, neither a member of their family or a close friend. It is really helpful to be able to talk to people who are going through similar things. It's a bit like when you have children, you know, you sort of need to have somebody to talk to who you're going through. So some of it isn't necessarily terribly costly. And I think you've highlighted some of those things there of cutting through some red tape, you know, where Merton can do so. And perhaps some simple things like, you know, just through befriending and stuff like that, to be able to have the time to as I think is really comes out in the report from some carers to be able to have a break, you know, and some people saying, well, you know, how do I have a break when, you know, I have sleepless nights if you've got young children and then you've got other caring responsibilities. It is really tough. So I think the prevention side of life really does help to come through if people can have access to certainly digital, and we all know how important that is at the moment as we're all here on digital screens, but also some help with IT to be able to do these things. So, you know, it's really ensuring, because we had a very good Merton adult education, you know, Watley was at one point I was able to access. So it's making sure that people can still have access to things like adult education and computer literacy and actually through, and we know the DONS group, there's been various groups that are actually been brilliant at providing laptops and so on, and some technology for schools. So there's no reason why things can't also happen for carers as well. It's really a question of linking things up. So I think this strategy is great, and I really hope that we all help to implement it in whatever ways we can. But as I say, green gyms in parks are great, and there's various ways I think that people can do things. It's a question of helping and supporting them to do things. Thank you, and thank you for putting this through. To say, I think the more that we can look out for each other through it, then that is very helpful. Thank you.
Thank you, Rob.
Thank you, Chair, and you'll have to forgive me because I'm due on a shift at Samaritan, so I'm going to have to make my comment and then leave. But I just wanted to say this is hugely impressive, and congratulations to you all. The approach is spot on. I think recognising the diversity of carers, the diversity of caring roles, really important to capture, which you've done really well in this. So wholly support it. And from an Age UK perspective, whatever support you need from us, whether that's joining the implementation board or whatever that might look like, you have it in spades. Really, really supportive of this. So well done.
Thank you. Hannah.
Thank you. And I think there's two observations I just want to probably finish with before you move on, Chair. One is recognising the importance that one cap doesn't fit all. That when we talk about carers having a break, it means something so different to everybody individually. And I think Una gave us an amazing example of that. So it's not about creating a model that you implement and everybody just fits into it. It's about having those individual conversations and us recognising the individual work that every amazing carer in this borough does, and more so now than ever in relation to the challenges we faced last March, and the way it wasn't unexpected, the way our carers just stepped up and took on amazing and additional responsibilities, and we must make sure that as we move forward in resetting, that those carers have got a voice, and we understand that learning, that when they had to step in and protect loved ones, what can we learn across health and social care from that? I think that's incredibly important as we move into the implementation phase. I want to echo what John said. This was never about a strategy that was nice and bound and you read it and it looked great and we put it on our website and everybody said, we've got a strategy. This is real. It's incredibly real to the people out there every day that takes care of family members, loved ones. So it's very, very important that we focus, and I'm really pleased for the Health and Wellbeing Board to welcome us back and keep that challenge going in how your implementation plan, and hopefully we being able to describe to you as a board how the impact of that implementation has happened as we move forward in the next year. So that was my first observation. And Chair, there was a second observation I wanted to make. So I don't often do this. We had some members of the team work on this. That is part of a graduate trainee programme. And we do this every year. We bring and hopefully encourage amazing, bright, young individuals as part of the LGA graduate trainee to come and work with us. And we all kind of compete as departments because we're all desperate for that energy. But also I think for the challenge that young, bright minds walk into an organisation and ask us, well, why are you doing it this way? Did you think of this and did you think of that? And I feel incredibly proud that we had two amazing graduate trainees, Jenny and Jacob. They probably had very little contact with adult social care, certainly community and housing, and arrived at Merton Council as part of a programme and gave us challenge every step of the way, and had that amazing ability when we talked about things to challenge, say, well, why are you doing it like that? So I want to thank them both for that challenge and for getting us here. This is their work as part of our team. They have taken us on this journey and they have challenged us as well. And it's great when you see organisations opening up their doors and other people walking in that knows very little about or has never had that contact with the world of an incredibly complicated system like health and social care, and can walk in and share and present like they presented this evening. If we can encourage more young people to come and work with us across councils and healthcare, I think we would have amazing individuals as we move forward. So not signalling anybody out, but I'm very, very grateful. Thanks to both of them. Thank you, Chair.
Thank you, Hannah. Were there any further comments or questions? Mohan, yes.
Sorry, just one last thing, and I think Heather and I caught up before this as a default, actually after another meeting, but it's just about the health checks bit, and I think we talked about how for carers, we're looking for checking on their health as opposed to an official health check. So I just wanted to get that sort of noted as we're all aware about that. But yeah, that was it. Thank you.
Thank you. I think ultimately just an overwhelming level of support for what is a really important piece of work. And I note that we're being asked to approve the carer strategy as part of this meeting. And I think an overwhelming amount of support and approval for this. And can I also extend our thanks to the carer strategy task group, all the carers and the professionals who took part in helping to pull this together. Thank you. And then finally, moving on to agenda item 6, which is the Merton CAMHS and Emotional Wellbeing Strategy for 2020-2023. And I believe that Dagmar will be introducing briefly before Sarah Keane presents the strategy for us. So I'll hand over to you, Dagmar.
Thank you very much. And in a way, Hannah's closing word were quite good opening words, because I want your support for the CAMHS strategy. And again, I'm turning it around a little bit. I start with a big thank you, particularly for our partners, our commissioners, providers, but particularly for the young people and families that have absolutely co-produced this piece of work. And initially it was to inform you, and I said no. You know, the Health and Wellbeing Board doesn't need to be informed. I wanted active. We need your help. We need your help in the delivery. We need your partnership working, ingenuity, and also a nudge of widening and strengthening working with young people. And I think the previous example was actually brilliant. So that just as a few words of introduction, how the CAMHS strategy actually really links with what the Health and Wellbeing Board is about. Hopefully loads of you will still remember we did the work around what is a healthy place, because that's what the Health and Wellbeing Board is. Young adults said, it has to promote my emotional and mental well-being. And so we've said, okay, we need to create a place, the conditions in which people can thrive, and we have to offer the services. So this is now an example of mobilizing what mental and emotional well-being services we want to provide, and we already provide in Merton. The other bits, just to double check, because what is it that the Health and Wellbeing Board will look at? Are we in a way confident that our principles have been adhered to? And I can only recommend it, because a focus on inequalities is what we have committed as a Health and Wellbeing Board. So when you look at the strategy, check it out and challenge a commitment to prevention, and above all, really, let's not fix problems for people, work with people, work with their strength. They know solutions. And I think I recommend this strategy because it has really adhered to these principles. COVID has brought the mental health and well-being of young people into a really sharp limelight. We had already before quite a lot of anxiety around self-harm. So it's very timely. The voluntary sector plays an increasingly important role in support, and we are really blessed that our Health and Wellbeing Board is so strong. And obviously, we've already talked about digital is just a new world that we are now more honestly including in our solutions. And young people are pretty good and can help us to open that up. So without further ado, I'm very grateful for Sarah Keane to give us a bit of a flavour, and then ask the board to really put their sort of effort behind the delivery. Thank you.
Thank you very much. Chair, I wanted to find out if it's okay for me to stay off camera just because my system keeps lagging behind and cutting out. Will that be okay?
Yes, of course, that's no problem. Thank you.
Fantastic. Thank you very much. I think Dagmar has summarized quite some key points, and so I'm thinking I'll tailgate on those the narrative she's given and continue there. But it was very interesting to see the themes that are emerging tonight, and a lot of it is focusing on prevention. And I think this is what is also going on around the camps. So you would see from the camps that I think the focus, what I'll do tonight is just a brief synopsis on the issues on what has been achieved so far and some of the challenges that we're hoping to work through in the coming years. What I also need to say is there's an easy read version which has been completed with our young inspector in the borough, so that's also available for that purpose. The other thing that is worthy of note is that we do have an action plan of the key activities that will accompany this so that our partnership is accountable to some of the timelines and the key activities that are linked to some of the actions in that sense. So thank you for that. The strategy is very much focused on how we can continue to support and enhance our children and young people's mental health and emotional well-being. I think looking at a strategy, it puts on the lens of early identification and early intervention. What we want to do basically is the right identifying issues at the right time and providing care at the right place for the right person. And this is through the lens also of working with children and young people, families, and the partners across the children and young people environments. It's quite exciting coming from a different borough to see how well the partnership works together in Merton. It's a very strong partnership, and it's fantastic to see that, especially in supporting children and young people. One of the key things I noticed when I joined the borough, that was in 2019 March, is the cohesiveness of how people are so passionate for the health and well-being of children and young people. It's very exciting to see. How will we achieve this? One of the key things that the document is driving is around the I Thrive. So the I Thrive concept is quite a key one, because within the CAMS provision, we do go, in the past, it has been around the tiered, tier 1, tier 2, tier 3, and tier 4. And what they've noticed nationally is that within the tiered system, oftentimes we have some gaping holes that can emerge, because a young person might be referred for a service, and then they will say, oh, you don't meet tier 2 or you don't meet tier 3. And then, as I say, the child or young person falls through the gap. So we want to basically cement some of the gaps that exist within those tiered system with the introduction and embedding of the I Thrive concept. And the concept is very much focusing on what Dagmar was saying about building strengths that our communities already have, and also working in a holistic way with emphasis on the need rather than the diagnosis. Because if we work with diagnosis, we don't have a neatly fitting service in that sense, because we know that we're dealing with human beings, and as human beings, we're complex, we're diverse, and our needs are quite unique. And so that is the focus of the I Thrive. So we're working at the moment to embed that concept within Merton, and that's an area that will be really helpful as a partnership to see how well we can be supported in that, especially as demand is beginning to increase, is increasing because of the challenges of COVID. The other thing that the document is really addressing or looking to address is around the inequalities within our health provision in the borough. And some of the areas we want to really develop to address the inequalities is around the Mitcham area, the east of the borough school. So one of the areas we're thinking about is around, for schools, introducing the mental health support teams in schools. Can you hear me?
Yes, we can hear you.
Okay, thank you. I'm just asking just in case I'm cut off. So the mental health support teams in schools is a very interesting concept, and one that is fantastic because it addresses the early identification as well as early intervention at that sort of early stage. And so we want to start looking at introducing that in schools in Mitcham and also Merton. We're in the process of talking to the provider so that we can look at how well we can cluster the schools around Mitcham and Morden to form a cluster. As you know, or some people might know, we do have some mental health support teams in our first cluster, which has about 16 schools. And then we have a SEN cluster, which is focusing on our special educational needs young people, which is a joint cluster with Merton and Sutton. And then we have a Southwest London facing one, which is the further education. And that is, the focus of that is around transition. And then we looking to the Merton, Mitcham schools, and then the Morden schools. That will leave an area that we're hoping that when there's another expression of interest, we will sort of bid for that. That would be in the Wimbledon schools. If we are successful, what it will mean for us is that we will have mental health support teams going into all our schools in the borough, which will be very exciting. It's a very exciting idea, and we're hoping it will work out. Some of the areas we're also trying to innovate around addressing some of the health inequalities is around our trauma-informed approaches and helping to reduce some of our youth offending young people who are sort of on the edge of offending and all that. And we're hoping to employ a specialist clinical psychologist to sit within the youth offending service. And the whole idea of that role is that they work, first of all, in close relationship, direct work with our children and young people who are identified as high risk and possibly on the fringes of getting into the criminal justice system so that they can work in a trauma-informed way with them. We also want to work with our workforce, so the clinical psychologists will sort of do some training for the workforce across the borough on trauma-informed approaches, because we're saying that for any family that is within that framework, generally what happens is the trauma is transferred to the young person and then it just continues. And so we want to address that through the training of the workforce so that we work in that with that approach in mind. The other thing that the post will also help with is working with some reflection within reflections and supervision type for the workforce around our young people who are within that cohort. The other area that we also want to work with is within the health inequalities or addressing the inequalities is around our pupil referral units. At the moment, we have a CAMS worker who is embedded 3 days a week within the PRUs, the pupil referral units. And as you know, our PRU environment is the evidence suggests that is sometimes the breeding ground for our gangs and all these in the youth environment. And we want to start addressing some of the issues before they become issues that become difficult for us to contain. So we are increasing some of the CAMS inputs there so that we can work directly with the young people there and then link them into that psychologist that we are recruiting and then work within that environment. So that's one of the things that is happening there. The other thing that we are hoping to do is basically, we have started actually, but we haven't got the outcomes that we were hoping will emerge. We started piloting a self-referral into CAMS, a direct self-referral into CAMS, and also what we call a brief intervention within CAMS. But unfortunately, because of COVID, we haven't had the uptake that we were envisaging would happen. And so we are reviewing that to see how best we can manage that, or whether it's something we need to perhaps continue or do something else with that innovation. So that's also our standing. Some of our challenges, I suppose, this is not news to most people who are who live in Merton, is that our neurodevelopment, our diagnostic pathway is challenged at the moment. We do have quite a lot on the waiting list. This is not unique to Merton, as it were, or Southwest London, is across the country. Every area is struggling with huge waiting lists to do with neurodevelopment diagnostic pathways. And within Merton, I think our challenge is slightly enhanced because we appear to be an outlier. So we get more referrals coming in for diagnosis than any of our neighboring boroughs. And some of the thinking around that, or the hypothesis we are concluding is, and of course there's no direct evidence for that, but based on the narratives we're hearing, we have done quite a lot of training within the workforce around the neurodevelopment, identifying some of the indicators that would tell you that our children and young people need to be supported quickly in that sense. And so that could have increased the referrals into the team. Our parents are also very well advised and also very much aware due to training, working with our special schools and the SEND team and all others. So they are well informed. So the workforce coming through and our parents who know how to refer and how to seek help, which is very positive, has also meant that possibly the increase is as a result of that. But this is an area we're really working on. So it's a key priority for us. We're working very much around developing a local pathway. And we're currently in talks with our educational psychology team. We're going to be talking, I think it's tomorrow, the meeting, to see how we can innovate with a local pathway, because they go into schools to see the children and young people already, so they are well placed, and to recruit a clinical psychologist who could possibly do the assessments and link up the speech and language and all other areas so that the diagnostic pathway is sort of clear, working with our SEND teams and all other areas. So that's an area we want to innovate on the neurodevelopment to reduce the waiting times. The other thing that has been a challenge was in 2019, we did commission ADHD, ADHD assessment to be happening in our CAMS team. So we were hoping that a psychiatrist would be recruited to do three ADHD assessments per week for us. But unfortunately, they haven't managed to recruit a psychiatrist. As you know, psychiatry is a very difficult area at this time. And I think the training, they are not training enough. Let's put it that way. And so what is happening is today, I did meet with one of the doctors who was working as a locum there, and she's quite interested in applying for the role, which is exciting. So if she does apply, it means that, I think she said her interview is in about a week on Monday, which means if she's successful, it means we'll have somebody who would also start working on the ADHD diagnosis pathway, which means that it will work towards reducing that challenge that we have. But in the meantime, some of the things we have put in place to support our parents around that is we have a peer support program, which is really exciting. I think it's quite innovative, and perhaps some people might agree with me. It's parents with lived-in experience who have had a child or they've cared for a child with autism, now sort of supporting parents who are currently experiencing that. And it's a very innovative service, I think. They came to the partnership board to talk about the service, and the recommendation and the evaluations on that is highly positive. Those are some of the things that we are providing around that. We are also providing what we call early bird. So it's an educational program for parents as part of the support that we have in place. The other area that we're looking at is that is quite challenging also is around what we call the behaviors that are challenging within our children and young people, and how we support them to be stabilized. So with that in mind, we're looking to innovate to see what we call a positive behavior support intervention. And that's another area we're working towards. We're working with our local authority colleagues and our SEN colleagues. We're in talks at the moment to see how we can embed a role like that to support our children and young people who will benefit from that. Because what is happening is at the moment we're commissioning individually per child, and it is a bit expensive that way. So we're trying to get a role in place so that we will have more of an informed approach around that. So that's so far what we are doing. I'm happy to answer any questions. And so with that in mind, sorry about that, Councillor, what we are hoping is to find out from our colleagues around the table in terms of how we can continue to hear the voice of children and young people in the delivery of our services, and also how well we can work with our voluntary sector organizations with this strategy in mind. Thank you.
Great, thank you so much, Sarah. And I think it follows on from another sort of ambitious strategy, which highlights a commitment to co-production and ensuring that the young person's voice is embedded in that design. So thank you very much for running through that. And I suppose just opening up to Sarah's point around how we can continue to ensure that the young person's voice is embedded. Both sort of colleagues around the table, if they have any thoughts on how we can ensure we do that. Rachel?
Thank you. So there are two ways, probably. Well, there are multiple ways, but there are two main ways of thinking about young people's voice, and we're getting increasingly good, I think, in all our organisations at embedding young people's voice in our development of strategies and in our design, and in some cases in the delivery of services through processes of co-production. We invite young people to get involved. We invite young people with experience sometimes of the services that we've provided to help us when we're in a commissioning phase or a strategic development phase, and we work with them and support them to be kind of helpers to us and supporters to us, and involved in the process of developing strategy and commissioning and delivery. And I think that's really important, and I'm proud of some of the work we've done in this area. But one of the key areas in which many of us fail to hear young people's voice is as practitioners, as clinicians, as people delivering services to children, as people delivering services to young people. And it's amazing how often we find people talk about getting young people's voice without actually listening to young people when they are speaking to us. This is my last Health and Wellbeing Board here in Merton, and on a kind of parting note, that would be the plea that I would make is, when we talk about young people's voice, let's not just think about how we professionalise our young people and listen to them when they are engaged in an activity that we've invited them to participate in, and where they're doing what we want them to do and they're doing what we ask them to do. But let's listen to our young people when they're talking to us about their health and well-being, about what's going on in their lives, about what they're enjoying in education, about what they're disliking in education, about what they're afraid of, about what their hopes are for the future. So if we strengthen our listening as practitioners, we will do the second element of that very important work.
Thank you, Rachel. Councillor Stringer, did you? Thank you.
Thank you. I agree with what Rachel said, obviously. Always agree with my director. That's the rule, right? But I was going to make a different point actually about. So yeah, this is really ambitious strategy. Thank you, Sarah, for all your work on it. And it combines everything from the prevention and the Thrive approach to more targeted support for those who are more vulnerable and more at risk. And it is ambitious. And as you said, there are lots of challenges. And I was going to ask about how we as a board are going to hold you to account on it, and how we're going to make sure we monitor progress. And I think your question about how we can involve young people is a very relevant one, because young people should also be involved in letting us know how we're doing, and whether all these nice things that we're saying we're doing in schools are actually landing in schools, or do they even not know that they're part of a Trailblazer service and they don't know where to go to still. So on top of Rachel's point, I think that's a third big area for me, is hearing young people's voice to give us updates and hold us to account and give us feedback. But thank you for your work on it, Sarah.
Thank you. Simon and then Mark.
Yeah, just a great piece of work, Sarah, as Councillor Stringer and Rachel recognised. I was just interested in the what is a cross-cutting theme of so many things now, which is about digital inclusion. But I wonder, with the point Councillor Stringer made about, and Rachel, about engagement, is we have got a situation due to the pandemic where a lot of young people have had to work over things like Zoom in terms of their education. So it's a media that they're getting more used to, as to whether we can use digital involvement, if you like, as a way of listening more. I think Rachel's term is a great one. We need to make sure we've got two ears and one mouth, as they say, to make sure we're listening well to them. But maybe there's some opportunities, because I think from everything really we talk about, the digital inclusion agenda and making sure that we can communicate by that media is important. So there may be an opportunity there as a way of engaging more with a wider audience of young people, to both challenge us back, as Councillor Stringer says, on are we delivering against the targets, but also to make sure we're listening well. Thank you, Chair.
Mark.
Well, I've got a couple of points, but I'll try and whip through them. So I think first and foremost, I welcome the strategy, and I think it is ambitious, and it covers a really wide range of services, doesn't it? It's CAMS covers it's an umbrella term for a lot of really good stuff. I think in terms of, I think Rachel hits the word on the head. Listening, we need to listen, but we need to listen opportunistically. There's lots of times we touch children, slaves, in various times, whether it be online via support mechanisms or indeed some of the services that are now going into schools. We should use those contacts to kind of inform what we're doing going forward. So really use the opportunistic stuff to listen. It's great that this has to be a partnership approach. I think with CAMS, it will only work if all the partners in the system are working together. And it's great, there's some fantastic innovation. I'm a newbie to Merton, and I have to say that, you know, there's some really good stuff going on in Merton in this field. But we should also address some of the challenges around access. And that's something that has come to me a few times over the last couple of weeks. I think Sally might have even raised it with me today at the patient group, but absolutely make sure that we're also making sure that all these services are accessible to a wide cohort of children.
Thank you. Mohan, and then if we go back to Sarah.
Yeah, I completely agree with all the comments, and certainly very good strategy. And I suppose it's worth, I think, Sarah, we're due to meet soon. I've been dealing with Helena about CYP for social prescribing. And as we know in Merton, social prescribing in Merton's a pretty good infrastructure across the borough, and now it's sort of growing its delivery. And there's been a big interest in CYP for social prescribing, but obviously we don't get as great a footfall in general practice, but actually we do get other things related to CYP which do enter us, and actually how does that affect the wider network. So I'm really interested and really happy to kind of also look at how we can support that with the existing infrastructure, building on our assets. So yeah, I thought I'd just mention that. Thank you.
Yeah, I wanted to say thank you very much for the feedback, and I think that the last point about access is a key one that we really need to look at, especially as we are having surges in different areas. So it's something we constantly have to have on our radar. So we will definitely bear that in mind at the board. Thank you.
Thank you, Sarah. Were there any final contributions to this? Great. So I think obviously a huge amount of support for this as well, and also keen to see progress over the next sort of 12 to 18 months, as to sort of Councillor Stringer's point. So we'll be looking forward to hearing from you again on this. But thank you very much for presenting to us this evening. And thank you also everyone for your contributions and for staying a bit late as well today. So unless there's any other business, I think that brings the meeting to a close. Thank you, everyone. Nice evening. Bye.
Bye.
Bye. Thank you.